Welcome to Variations 4, the respiratory unit. In this video, we're going to cover questions 4 to 6, and really the main topic here is effusions, pleural effusions, or pulmonary edema. Number 4, what is the cause of exudative pleural effusions? We've got a written explanation down here, which you can read through. Your main points is that it starts with what? It starts with inflammation. And then what does inflammation cause? The inflammatory process causes increased movement of fluids, cells, eventually cell debris, vessel permeability to get the fluids to the spot of inflammation. This vessel permeability allows these increased fluids to flow into tissues. And in this case, it would be the pleural region. So on your concept map here, you can see what I've just said basically outlined in pictorial form. These two things here. So this increased vessel permeability can lead to what? An exudative production can lead to what? So the body's producing all this exudate in the hopes of trapping pathogens, killing pathogens, carrying pathogens away. This is why we produce the exudate. The vessel permeability aims to try and get the exudate there, if you will, get the fluids there. And so you end up with an area filled with exudate. You end up with vessel permeability. If the inflammation is bad enough, like for example, in the case of some kind of lung trauma or some kind of lung disease causing inflammation, then you get that fluid flowing, and it could be going to both pulmonary edema or pleural edema. Pleural effusions or pulmonary edema. The terms are almost interchangeable. And we'll look at a picture in a minute that when we get to question 6, that differentiates between the two and how it would look like in a picture. So question number 5 asks about liver disease and CHF. So can you write down how each one may contribute to either pulmonary edema or pleural effusion? Now, the answer is going to be the same in terms of whether it's pulmonary edema or pleural effusions. It's the same pathway to get there. It's just the fluid's going to different places. It might go to one, it might go to the other, it might go to both. In terms of how this happens, well, with liver disease, as you know, you have low albumin. You get decreased oncotic pull in the vessels, and fluid flows to tissues. The CHF, you know, you've got increased hydrostatic pressure. So if you remember back to this video from Unit 1, it was question number 11 on hydrostatic pressure. Remember that hydrostatic pressure, in the case of CHF, you've got these blood vessels are just loaded with blood and fluid, and basically you have volume overload with CHF. You've got congestion, and that congestion puts increased pressure on the vessel walls and pushes the kind of the water portion of the blood out into tissues. And so surrounding tissue areas will become filled. And again, that could be the pleural region, that could be the pulmonary region. And that's what we see here in this concept map. If you choose to read through that, that's exactly what we're seeing. And the concept map talks about ways to deal with this. As we know, with albumin, low albumin, and albumin transfusion can work, but only temporarily until we solve the actual problem that's causing a low albumin. If it's liver failure, there's nothing much we can do. It's going to be a recurring problem. But the focus of this chapter is really about what do we do about fluid in the pleural space. Now we're kind of on to question number 6 here, which is how do we deal with these things? How do you deal with pulmonary edema? We'll talk about that in a second with the diagram and how do we deal with pleural effusions. Let's talk about question 6 in terms of a diagram here, and this will help us to really uh, separate the two concepts. All right, so with pulmonary edema, it's something you should know quite well. It's quite common. You see it a lot in the elderly, in your long-term care facilities. Why do you see pulmonary edema to one extent or another? Or, you know, or at least crackles. Why are you hearing crackles on these people's lungs? They're not very mobile. They're not very mobile, so they're not really moving secretions around. That's one reason. Two, they don't have the most, their thoracic cavities, everyone's thoracic cavities becomes more rigid in terms of musculoskeletal movement over the years. And so they're not getting as good ventilation. They're not taking those deep breaths that they used to when they're younger. And the bottom line is, you know, any kind of respiratory illness aside, because you know those cause exudate in themselves, but even that aside, many elderly people who don't move around enough or deep breathe enough get fluid buildup here and there, and you know whether it's serious or not just depends on how much. When you wake up in the morning, or someone you know wakes up in the morning, listen to their lungs before they get a chance to take a deep breath. You may be surprised to hear a few crackles. As soon as they get up, walk around a bit, take a deep breath. A lot of people cough once or twice in the morning. Listen again. The crackles are gone. Try that in the hospital too. Comparing what you hear in someone's lungs as they're waking up versus when they're dangling at the bedside now, had a bit of time to move around. They usually clear up. Anyways, that's pulmonary edema. That is the little bit of moisture, or a lot, depending on the problem, but moisture on the alveoli, on the tissue itself of the lungs. How do we treat that? Well, deep breathing and coughing, raise the head of the bed, get some movement going on. Hopefully that solves most of it. If it's bad enough and that's not solving it, then you may need to use diuretics. Hopefully none of that is incredibly new to you. What is new this unit is the pleural effusions. This is your normal pleura. This is your pleura that has effusions in it. How do we treat that? How would we get air or fluid out of there? We stick a chest tube in, and let's take a look at some chest tubes here. So you see a thoracic cavity. Obviously, this patient has some kind of fluid and air in the pleural region. We'll take a closer look at exactly what a chest tube is when we go to our integrative nursing practice course. For now, we're just keeping it all theoretical, and this is the chest tube inserted in the upper part of the chest. This is the chest tube inserted in the lower part of the chest. So sometimes you'll see patients with two chest tubes inserted. The chest tube goes into the pleural region. What do you think the higher one drains? What do you think the lower one drains? If it's hemothorax and the fluid has drifted downwards, as it will with gravity, the lower chest tube removes fluid, and the higher chest tube removes air, because air rises. So depending on if it's pneumothorax or hemothorax or both, you're going to see one or two chest tubes. There's also something called the pleurocentesis, or in this case, they call it the thoracentesis, is going to the thorax. The same thing. The physician sticks a needle into the pleural lining and withdraws fluid. That might be just a one-time thing to remove some fluid. So that's a choice that they could do one time rather than put the chest tube in. Well, sometimes if the patient has a bit of air in the pleural lining, and that's all they have, and it's not something that's incredibly acute, they'll get put in what's called a Heimlich valve. There it is spelt down here. And there's a picture of it. And here's a picture of one attached to the patient going into the pleural lining. What this does is it allows air to come out, but it does not allow air to come in. And patients can actually go home with that. And finally, you should look at this map here. on map number 4, which is the head to toe for pleural effusion. And you can read through it yourself. A lot of it is very intuitive as to what you'd find if you think of how each bodily system would be impacted with something like a pneumonia or a chest trauma, fluid or air in the pleura. If you think about what effect those things would have on each system, then it really does make sense. A lot of this we've discussed already. A lot of the diagnostics we've discussed. There's only 2 or 3 points I want to highlight here because the rest should be pretty intuitive as you read through it. Things I want to highlight from here. Number 1 is this thing about pleuritic pain. So anytime you have inflammation of the pleura, that could be from pneumonia, that could be from trauma, it could be from chemicals, inhaling smoke, many things. You have pain then whenever you breathe in. It's difficult to breathe in deeply because it increases the pain. Even worse, once you get the chest tube put in, the chest tube itself is painful when the patient breathes in deep. So if you want to avoid further pooling of fluids in the lung tissue, or I guess, it would be the pulmonary tissues in this case, you really need to manage pain. Analgesia management is huge for anyone with pneumonia, whether or not they have a chest tube. The second point I really want to highlight here is the difference between hypoxia and hypoxemia. One is usually precedes the other. Which one precedes the other, and which is the one that causes us to see signs and symptoms in terms of changes in bodily systems? So yes, hypoxemia will usually precede hypoxia. And you could have hypoxemia and be completely symptomless and have no issues. But once the organs start being affected, you've got hypoxia, and that's where your signs and symptoms start to show up. Finally, there's this thing called pleurodesis. Pleurodesis is not for every patient by any means, but some patients who have recurring pleural effusions, who don't want to keep living with that, have that space obliterated. Basically, it's sclerosed, turned into fibrotic tissue, essentially, bound together so they can keep living. They may have a little bit of difficulty and discomfort when they breathe in deeply, but they definitely won't have to worry about pleural effusions again because they've sclerosed the area. Look it up if you want to know more about it. It's just something interesting to note.